countries and continents, were really focused on trauma, obstetrics, vascular, renal, and hepatobiliary conditions. Since then, we have seen a proliferation of applications that include pulmonary, COVID-19, cardiac, ocular, the acute abdomen, testicular, musculoskeletal, soft tissue, vascular access, and ultrasound-guided procedures. The dedication of emergency physicians for advancing care has not gone unnoticed. In the United States, the American Medical Association, our leading organization for physicians, advocated for the use of ultrasound by all specialties and not just radiologists. In 1999, the AMA came up with this ultrasound policy that stated that ultrasound use was within the scope of practice for all appropriately trained specialists. All appropriately trained specialists. This policy was amazing, and it really helped pave the way toward helping advance ultrasound care for acute care physicians, and it helped us win the political battle of getting hospital credentialed to use ultrasound at the point of care. However, there remains much work to be done. This movement has been incredibly exciting, and all of us globally have continued to help move it forward and bring some tremendous growth. This historical movement in clinical medicine was advanced because we as emergency physicians are passionate about advancing the highest quality of care and safest possible care for our patients. Presently, there remains a plethora of point-of-care ultrasound activities. There are just too many for me to review in this lecture. One current application of emergency ultrasound that I would like to touch on is the use of point-of-care ultrasonography in the pre-hospital and austere environments. Pre-hospital ultrasound allows caregivers to dramatically increase the amount of diagnostic information gathered and really helps reduce the time to diagnosis. Information obtained can be used to appropriately help mobilize the acute care and definitive resources at the hospital and really accelerate and improve these interventions at the hospital setting. Our colleagues from Europe, Asia, the Middle East, and Australia have demonstrated very innovative ways to apply point of ultrasound in the pre-hospital environment. Clinical indications for pre-hospital ultrasound are similar to the indications in the hospital setting. The main difference is that the pre-hospital setting are the limitations of time, space, and provider training. Tactical and combat environments have a high potential for injury from explosive and penetrating trauma. Ultrasound is useful for evaluating causes of shock, looking for the presence of pulmonary, cardiac, and abdominal and vascular injuries, and potentially assessing for increased intracranial pressure via optic nerve diameter measurement. In penetrating torso trauma, ultrasound can provide data for triaging patients and providing potential point-of-care interventions. Ultrasound has been used to provide care in the field environment and after several disasters, including earthquakes, where it has been found to be a reliable diagnostic modality. Urban search and rescue teams may use ultrasound to assist in identifying injuries, prioritizing interventions, guiding fluid resuscitation, and determining the pace of rescue operations during entrapment situations. A landmark paper was published in the Journal of Ultrasound Medicine in 2001. It described the utility of point-of-care ultrasound after the devastating August 17, 1999 earthquake in the Marmara region of Turkey that resulted in 17,000 deaths and over 100,000 injured. Of the 5,300 patients admitted to the hospital, 639 had renal complications and 477 underwent hemodialysis because of acute renal failure from crush injuries. Doppler ultrasonography was used to measure renal resistive indices within 16 to 32 hours after the earthquake and 6 weeks later. The resistive index is estimated from intrarenal blood flow impedance. Renal resistive index increases as a reflection of renal vasoconstriction. The authors found that all measured initial renal resistive indices were high, and they were correlated with the number of hemodialysis sessions and the duration of hemodialysis treatment. The authors concluded that in crush injuries, measurement of renal resistive indices can be useful for the prognosis and from recovery from acute renal injury. Low Earth orbit represents one of the more unique environments where ultrasound is employed. After 25 years of continuous human presence aboard the International Space Station, ultrasound remains the only imaging modality that is used for medical research and for acute care. In-flight ultrasound images are obtained through a unique training model where crew members receive approximately 40 hours of medical officer training that familiarizes them with medical equipment and procedures, and allows them to act as physician extenders for the flight surgeons in mission control. Crew members are taught how to place the ultrasound probe on a patient and then to adjust the transducer in response to an ultrasound expert's verbal guidance. Ultrasound can also be used to support clinical decision-making in the management of acute injury and acute illness. So let's just take, for example, that a crew member should develop an acute pneumothorax after an overpressure injury, or let's say they develop acute appendicitis. Point-of-care ultrasound can then help make decisions in acute interventions to save their lives, or in some cases, evacuate that crew member from low Earth orbit. So as NASA pursues exploration class missions to the Moon and Mars, the training and operations model for the use of diagnostic ultrasound will need to change. Deep space missions may require a crew member with advanced ultrasound training and onboard resources that support autonomous ultrasound use. So as we move forward, how can we best advance emergency ultrasound? How can we improve the quality of applications to serve our patients around the world? Expanding and improving educational opportunities, I think, is always a wonderful place to start. In my opinion, we should focus on two areas. First, teaching all medical students around the world how to use ultrasound from the very beginning of their medical education. And second, making a concerted effort on teaching acute care and primary care physicians in rural settings on how to apply some of the most important aspects of emergency ultrasound. In a few United States medical schools, such as the University of South Carolina and others, ultrasound is being introduced to medical students from the very first semester of their medical school education. I would love to hear from all of you if there are similar initiatives being undertaken in your home institutions and home countries. How early are medical students starting to learn? Who is teaching them? What applications are they learning? And is this being paired with their gross anatomy education? This is a very famous quote after a very, very important technological advance. I think all of us recall the enthusiasm and initial excitement after we learned how to use the stethoscope in medical school. I mean, it was just so cool to listen to breath sounds and bowel sounds and listen to the heart, valves opening and closing. But I think we all recognize today just the limitations of using a stethoscope. That's why I am proposing the Resus Project for every medical school worldwide. Let's replace the stethoscope with ultrasonography. Can this be accomplished by the year 2030, or maybe in 10 years by 2034? I'd love to hear your thoughts on whether you think this is a viable endeavor. And how can we work together to make this change? How do we develop an introductory ultrasound curriculum that can be rolled out to medical students throughout the world? Because I think we all agree that starting them young is the key to success. My second proposal is to focus our educational efforts on acute care physicians and primary care physicians in rural areas around the world. In the United States, many acute care physicians in the more populated regions are very adept at using point-of-care ultrasound. From my experience in teaching ultrasound courses in the more rural areas of Oregon and Kansas, I've just found that most of these clinicians never have the opportunity to learn point-of-care ultrasound. It's usually from a result of never having the opportunity to get that education, that basic education, or sometimes it's that they didn't have these resources to purchase an ultrasound machine for their hospital, and sometimes it's just both. So again, I would love to hear about your experiences. Do the clinicians practicing in the more rural environments in your countries have the training to perform point-of-care ultrasound? What are some of the issues impeding them? And how can we best help them? How can we help these clinicians gain access to learning point-of-care ultrasound, whether it's through education or providing them the equipment? Another important area of focus in the future is expanding international efforts to jointly collaborate on research projects. Presently, in my opinion, too much research is being performed in silos within each country, and often in silos within each institution. One example of a multi-center collaborative effort was the STONE project, which I was fortunate enough to have participated. The objective of this study was to analyze the most appropriate initial imaging modality for patients with suspected nephrolithiasis. This federally funded study involved 15 geographically randomly assigned patients to 3 different arms. The first was an emergency physician-performed ultrasound arm. The second was a radiologist-performed arm. And the third was CT. The study enrolled nearly 2,800 patients and demonstrated no significant differences in outcomes or adverse effects between the emergency physician-performed ultrasound arm, the radiologist-performed ultrasound arm, and CT. Registry of all point-of-care ultrasound exams that can be performed. Medical centers from across the world could participate by entering ED ultrasound exams into an internet-based ultrasound registry. The results would be pooled into large databases, and then we would find experts in statistics who would be able to mine these large databases and help answer some very important questions. Just a few questions that come to mind that could be addressed would be, number 1, how many point-of-care ultrasound exams does a student or provider need to perform to be considered proficient in point-of-care ultrasound? Right now, many societies 5 FAST exams to be proficient in the FAST exam. I've sat in on these meetings, and it's really just a bunch of folks coming up, I think it's 50 FAST exams. Well, let's just come to the middle and we'll say 25. There really isn't any hard that can really help us come up with a specific answer. Number 2, how much cost savings can be seen when replacing more expensive imaging studies with point-of-care ultrasound? Third, what are the overall outcomes for these patients who undergo point-of-care ultrasound? Are they significantly different than others who don't? And how much quicker can we help expedite care and dispositions for these patients? These are just a few examples of some of the questions that can be answered, and there are just so many more. Finally, I would like to see us establish an emergency ultrasound certification process. The objective of this international certification process would be to recognize acute care physicians for their ultrasound training, experience, and expertise. They can then present it to their hospitals as a way of being credentialed in emergency ultrasound, which will allow them to become hospital credentialed and would help them avoid any political infighting and help get them for reimbursement purposes for all their hard work and efforts. Currently in the United States, the American Board of Medical Specialties, which is the umbrella organization for all 23 medical boards, they are sponsoring something called the Focus Practice Designation in Advanced Emergency Ultrasound. It's essentially a made-up and meaningless certificate for physicians to just hang on the wall. They get this thing, they put it on the wall, and they're supposed to feel good about it. It is not the equivalent of board certification. It's essentially another money grab by the American Board of Emergency Medicine to charge its diplomates. The combined registration and application fee is $2,200 US. This emergency ultrasound certification process is available to only American Board of Emergency Medicine certified physicians and it is not available, and it just completely excludes physicians from all other countries. Together, let's come up with a better process. Let's come up with something more meaningful and powerful, and it should be inclusive of all physicians around the world who meet the emergency ultrasound training criteria. This would carry real weight in their home institutions and demonstrate that they are indeed experts at emergency ultrasound. And finally, let's make it much more cost effective. I really believe that we can make it work for just a very small fraction of the current $2,200 that is being charged. Once again, it's just been a total privilege for me to address this at Congress, and I can't wait to meet each and every one of you after this talk, and I would love to hear your thoughts to some of the questions that I raised earlier, and let's discuss. Thank you very much.
Thank you very much, Dr. John Ma. It's a big honor to us to hear from you. If any question or comment? Yes, Dr. Boy. Mikrofon.
One idea would be to have them come up here and ask the question. It would help me too, because my hearing is going, and I've promised my wife that I'm going to get hearing aids eventually.
So excellent. This is Dr. Bhui from India. So this is excellent presentation, and we're really honored to hear you, Dr. Ma. It's a pleasure, and it's a dream come true to hear you on stage. So from all of us, we really appreciate that. Some of the thoughts which you have, excellent thoughts. It is the visual stethoscope of 21st century, point of care ultrasonography. So we'll love to, spread that across the world. And I don't have any thoughts, but I have agreement to whatever your thoughts are in that. Second is sharing the very important thing you said, the future. The future is, bringing it to the undergraduate level. So some of the, experience which I had in 2011, I met Dr. Richard Hoffman, University of South Carolina, when we hosted the World Congress on Point of Care Ultrasound at Delhi, AIMS Delhi 2011. So I had invited him, and I heard the experience which he had. I think that was early years of bringing it to UG level. They were doing it in South Carolina. So after that, we started imbibing that, and right now we are training. I'm teaching my undergraduates in sonoanatomy. When they go for anatomy dissection, before that we are doing say thyroid scan for for cardiac. Then that is imbibed. Already the anatomy department, they have bought a ultrasound machine in their department after the initiative, and we are now trained the teachers. So they are training their own students. So that is some of the experience which I had. And second thing is sonophysiology. So the second thing. So it will be very exciting to work in that area. And I really agree on your thoughts on that. So we're going to work and put it as a curriculum across the length and breadth of India. So good thoughts.
Thank you very much for sharing your thoughts there and the experiences. Yes, Dr. Hopman from the University of South Carolina was a visionary, and I had the chance to visit him there, and he demonstrated the ultrasound lab that first-year medical students were using, and I just thought that was brilliant. And how can we start translating that across the world, because I know it's not happening in the United States. There are just still a few medical schools who really do that. So it's wonderful to hear that you have brought that to India, and I would love to hear later or now what other experiences folks have been advocating for in their home countries.
One more thing, Dr. Ma, which I have a thought, that we have brought point-of-care ultrasound to the nurses in India. Nurses. I have trained all my nurses in point-of-care ultrasound, which I teach to my postgraduate students, PGY1 in emergency medicine. So I have got a curriculum for them, for nurses, and the clinical nurses on the bedside, they are using, especially during mass casualty. During peacetime, our residents, they do, and the radiologists in difficult cases. But in mass casualty, we are trained, and we are using nurses as the main person who does the triage. So tomorrow I have a presentation in disaster ultrasound, so I'll be focusing more on that, on task sharing model or task shifting model of using nurses at the ground, because they also are working in remote areas in India, remote. So we have trained some of the rural nurses in Arunachal Pradesh, that is the far northeastern province of India, where actually doctors are not there. Doctors' population are less, but the nurses are abundant. So there we have trained the nurses for doing point-of-care ultrasound for the rural folks in the northern part of the India. So these are some of the thoughts I had and experience from my side, sir.
Thank you for sharing that fantastic point. Yes, right now I just focused my talk on physicians, but yes, teaching, educating nursing staff and physician extenders like physician assistants and nurse practitioners, I think there's a whole lot of scope there that we could really make some advanced, pointed out, help create opportunities for us to help patients around the world. Thank you very much for sharing that.
Dr. Ma, one of the most important parts in the world of ultrasound is the cost of the machine. And the cost of the machine creates a very big economical barrier in the development of, or the spread of the usage of ultrasound. Technically, ultrasound outside the radiology department traditionally was in the hands of cardiologists. So the only clinical specialty which had access to ultrasound outside the hand of the radiologist used to be the cardiology department. Then ultrasound became a general practice when interventional cardiology evolved, that echo could be done by internal medicine experts, pulmonary experts, because cardiologists advanced to do intervention. But then they also opened boards for echo. So echo got more and more complex and more detailed as it evolved as a specialty. What challenge, personally as a deep thinker in emergency medicine, I face is this industrial influence on selling machines could lead to misutilization of ultrasound. Echo, when you want to learn, there is so much hard work and dedication which goes into learning echo. One of the things which I noticed in India in my last 20 years of developing academic emergency medicine in India is a phenomenon called a fool with a tool. So a fool with a tool is always a fool. So we were giving ultrasound, or it was being promoted by the industry to teach ultrasound to everybody who didn't even read the textbook. They were using ultrasound to replace the clinical exam. That is a lesson from India which the world has to be very careful about. If you start propagating, or this misconcept goes in the minds of young residents, that ultrasound replaces a clinical exam, there's going to be a very big problem in the practice of emergency medicine. Replacing the stethoscope is absolutely okay, but that doesn't replace the clinical exam. When do you use the ultrasound is something which you can only know when you know when to use it. If you don't read the textbook, if you do not follow the clinical protocol, if you do not follow a clinical exam, learning ultrasound won't be of any use to you. And there is always technology which can cause problems. There is no lobe, but in the hand you have a probe. There is no use. You got to have knowledge in your brain to be able to use it correctly. And that is a lesson from India, which I want to clearly tell the world that last few years we have been observing the misutilization of ultrasound by the industry to spread a misconception that ultrasound is a replacement of clinical exam just because they want to sell machines. And they hold workshops without trained teachers. So if there is no regulatory framework for saying who is an ultrasound trainer, every fool with a tool could be paid by the industry to teach ultrasound, and that could lead to misutilization and replacement of clinical exam with ultrasound. And this we have seen in India. So this is a very big challenge. Yes, it's good to use ultrasound. It's the same with CT. Abdominal pain, do a CAT scan. It's very easy. But if you do not know when to use a plain CT, when to use a CT angio, and when to use a CT with IV contrast, because mesenteric ischemia, if you use a plain CT, you're going to kill the patient. Mesenteric ischemia, if you do a CT IV contrast, you're going to kill the patient. So mesenteric ischemia needs a CT IV contrast, while mesenteric venous thrombosis needs a CT IV. So one is an angio and one is an IV. So CTA and CT IV. If you do not understand that and you do a plain CT, it's going to die. If you do an IV contrast, the mesenteric ischemia will be missed. Same applies to ultrasound. Just taking the probe and going shortness of breath, let me put the ultrasound probe. Follow the clinical exam. Find out why the patient is short of breath. Oh, let me look for B lines. Did you take history? Did you do a clinical exam? Did you do assessment? That's all important. So that is one of the points I want to bring to the crowd, is that beware of the industry. Because the minute you start democratizing the concept, the supremacy and the dedication to training and learning will go down immensely. And that could harm us, because the next generation are the doctors who are going to put a central line in me, you, and everybody else. And if we have fools with tools, maybe the central line will become central arterial line. Thank you very much.
Thank you very much for raising that point, and I couldn't agree more. There's still, at the end of the day, no substitute for sound clinical judgment. And the clinical exam is utmost important. I mean, what's more important, the history or the physical exam? We all know it's the history, except when someone has abdominal pain. There's no substitute for doing a thorough abdominal exam and letting your fingers know whether or not there might possibly be peritonitis or tenderness and things like that. It's interesting that the head of cardiology at Oregon Health and Science University was a gentleman named Dr. Sanjeev Kaul, who really pioneered the use of microbubbles for ultrasound. And he gave a talk once that said, where he declared he no longer uses a stethoscope. So he says that he's like, I'm a cardiologist and I don't even listen to the heart exam anymore. I use my ultrasound as basically a stethoscope, because I can see and learn so much more than trying to listen to heart sounds. And I thought that was very enlightening.
Okay, thank you very much.
Thank you, Dr. Ma.
Thank you very much. We have more time for the question. Thank you, Dr. John Ma. Thank you.
See you all at the party tonight.